behalf of Glaukos, welcome. My name is Glenn Fawcett. I'm the Vice President for Commercial Operations for Glaukos across Southeast Asia. And it's my honour and privilege to be here with you this evening to introduce the iStent Infinite product to Asia. Glaukos has been around for a number of years. In fact, the idea started back in 1998, and it took 15 years before our first generation, the iStent, was released to the market in 2013 in Europe. Since then, there's been a number of different iterations, continually taking the feedback from surgeons such as yourself on what works and what does not work to improve the product. So from our first generation, we moved to the second generation iStent Inject in 2016. And then the iStent Inject W with a wider flange in 2018. This evening and throughout this year, we're now starting to introduce the iStent Infinite, a 3-stent device with unlimited fires on the device, which we'll hear about this evening. So it's been quite a ride as this product develops and each of the markets that we all work in develops and adopts this kind of technology. This evening, I'm looking forward to hearing from all our speakers, but first and foremost, I'd like to introduce our moderator. Our moderator this evening is Professor Tina Wong. And if I had to go through her entire CV, we'd be here for another hour. So this is the shortened version, Tina, so excuse me. She's the past head of glaucoma at Singapore National Eye Centre, a senior consultant there as well. She's head of glaucoma research in ocular therapeutics and drug delivery, and also director of transfunctional research as well. Her focus is on new modalities to improve surgical and clinical outcomes. She holds 10 patents and is a co-founder of 2 biotech companies. She's a thought leader, and she's received many international and national awards. I'm always looking forward and enjoying what she says, her insights, and I hope that we will tonight challenge the way you think about glaucoma and the management of glaucoma with new devices such as the iStent Infinite. And so with that, welcome Tina to the stage to be our moderator. Thank you, everyone.
Thank you very much, Glenn, for the introduction. And it's always really nice to be here amongst friends from Glaukos and colleagues as well. So I think what I'll do is I will just introduce my fellow speakers here this evening, and then I will give a brief introduction as to what we're going to be talking about. Dr. Bobby Ang. And he is a senior consultant. He's a refractive surgeon, but he has been deeply involved in all the innovations and evolution of the iStent from the very beginning. And he is here in the middle of Makati City in the Philippines. And next to him is Dr. Colin Clement, who is a senior consultant and glaucoma specialist in Sydney. And then on the far end, there is Dr. Paul Singh, who's flown all the way from Wisconsin, which is I don't know how many hours and what time it is for him, but he's here. So, so it's really wonderful to see everybody. So, okay, without further ado, I think we will then make a start, and I will give a brief introduction to this evening's events. So let's get to the bottom of all this, right? Why we are all here. The latest launch of the Asia-Pacific Glaucoma Guidelines, the 4th edition, which will be tomorrow, it has been now confirmed that glaucoma is the major cause of irreversible blindness in the world. It's not a great sort of claim to have, but we've actually dominated over macular degeneration and diabetic retinopathy. That also means that our workload is going to be tremendously exponential, as we know patients are getting older and living longer. So what I want to talk about today is, you've probably heard the phrase about interventional glaucoma, okay? Because what is today's glaucoma management wish list? Perhaps it's different to when you were residents, when you were trainees, what your seniors and your professors taught you. That, you know, patients would have to stay on eye drops for a certain number of time until they get to a certain stage of the glaucoma, and then you intervene. But what I want you to all think about today is to have an open mind. And that's what all the speakers are also going to talk to you about. Because this is where changes happen. This is where improvements to our clinical practice to benefit our patients occur. So what I want to say is that it's not interventional glaucoma, it's early intervention in glaucoma. So for the English language, this is actually more accurate as to what we really want for our patients. Why is it? Because early intervention means that there are options, that you are considering an alternative to eye drops as first line. It also means that you are considering early laser or early surgery for that patient. And finally, you are also considering adjunctive treatments to eye drops, because really, what is important is the reduction of the risk of visual impairment to all our patients. And that equates to that one person who is in the middle, the patient that is living with glaucoma sitting in front in your consultation room. We want them to have the freedom to carry on living their lives. We want them to have treatments that are safe. We want them to continue to have good quality of life so that they can carry on with their lives, see their children, grandchildren, etc., etc. And we want to be able to, as clinicians, optimally manage patients to eliminate disease progression and blindness. So what I'm saying really here, and you'll hear it here for the first time, is that glaucoma diagnosis does not have to be a life-changing condition anymore because of the advances of technology, the advances that we are now seeing through all the devices, and the iStent being one of the ones, that are now something that we're able to offer to our patients. So I'd like you to think about this, that it's early intervention in glaucoma that we really should be chanting as our mantra as glaucoma specialists. So what I'd like to do now is I'd like to introduce the first speaker, who is Bobby Ang, and he will be introducing iStent Infinite and the FDA study.
Good evening, everybody. Welcome to Manila and the APGC, where the Philippine Glaucoma Society is very excited to host this year's APGC, and welcome to the Infinite launch. So finally, the Infinite is here. So I'm an investigator and consultant for Glaukos, and as Tina mentioned, I've been with the Glaukos study team for, I think, a decade, and we started with the iStent 1, iStent 2, Supra, Infinite, iDose, right? 5 products altogether. And that shows us that this company is serious at innovation in bringing glaucoma management to the forefront of care in glaucoma. So, as we know, mixed procedures have increased substantially over the past decade, and even with iStent 1 and 2, it has established itself as a safe procedure. And for those of us who have implanted the iStents, we know that the worst case you can do is put it in the wrong place. But there is no side effect. There is no bad effect to the eye. 90%, or at least on label in the US, the FDA approval is in conjunction with cataract surgery. So that's why 90% of implants are done with cataract surgery together. Now, standalone usage, since there is no on-label indication, is not reimbursed or not very popular, except that some doctors, like us, we do standalone. For example, those who have no other recourse but to have an iStent in their eye if in case their trab fails or something like that, then we use the iStent inject for them. So this is a minority. This is a photo of 3 iStents that we placed in the study. So the Infinite is 3 iStent W. So 3 stents in one delivery system. And if you're familiar with the iStent inject, there are 2 stents but 4 fires. You can only fire 4 times. This one, you have 3 stents and you can fire infinite number of times. So this way, you are not afraid to thread it again. In case you implant not very deeply and it falls off, you can thread it again and fire again with the same device, injector system. So why do we want to do early intervention with MIGS and iStent is if the patient has a stent that allows flow, it is 24/7, meaning unlike drops, where you put the drop, there is a few hours of effect, and then IOP rises again. So as we know, diurnal fluctuation causes damage to the eye. So if you have a device that allows 24-hour flow outside the eye, that helps. It's very easy to use. It is very simple, actually, to explain to the patient what you're going to do. It optimizes outflow where the problem of open-angle glaucoma is, which is the trabecular meshwork Schlemm's canal area. It is an easy injector, so it's easy to handle, and it's mixed. So it is, well, I describe it to the patient like a thumbtacks, like a small thumbtacks with a hole, and it occupies only 3% of the whole TM. So you have the rest of the TM to do as you wish next time if there are other technologies available. So the pivotal study, the study that was done to have the iStent Infinite approved, is to evaluate if it can be used as a standalone without cataract surgery. And what is the market, or what is the patient population that is not addressed now are those who don't need cataract surgery. So we have no on-label approach for eyes, for MIGS without cataract surgery in conjunction. And second is the severe glaucoma. So your on-label MIGS is mild to moderate glaucoma in conjunction with cataract surgery. What about the rest of the eyes that don't fall under that basket? So this study aims to address those eyes. So it was a prospective multi-center study, and we recruited two groups of patients. One group is those that had failed TRABs or failed glaucoma surgeries before, and the second group are those on maximal medical therapy, so at least 4 eye drops, and still uncontrolled. So these two groups are very hard to treat. So it's the first of its kind study where you're addressing the difficult patients and using a MIGS device for them. So no washout. Of course, these are severe patients. So unlike all the previous glaucoma studies where we do a washout for 4 to 6 weeks, this one, no washout. So we discontinue the meds on the day of surgery. So afterwards, no meds. And the main criteria for success is we want the IOP to drop to below 20% of the baseline IOP. So the same topical medications or less, that's what we want for the patients. So the trial endpoints, number one, the main endpoint is how many patients had 20% or lower mean diurnal IOP reduction at 12 months. Then the second is what is the mean change in IOP of these patients? And then are we creating any adverse events? So there were 72 eyes in this study. 61 of the eyes had failed surgery before, and 11 had maximum medical therapy. So this is a breakdown of the failed surgery. Some had TRABs, some have gel stents, some have shunts, some had bled revisions. So these are the really difficult patients. And then some are on maximum medical therapy. Now, some of you may ask, why is there less on maximum medical therapy? Because when I recruited the patient, you will encounter this. The reason why they're on maximal medical therapy and going blind is because they don't want to undergo any surgery. So even a study scares them off. So even TRAB scares them off. A study. So it's really, you will encounter patients like that, like, I don't want any surgery. So that's why it is more difficult to recruit the maximum therapy patients more than the intervene one, because if they fail TRAB, they know that, oh, what else should we do for my eye? So the patients have undergone at least 1.6 procedures, bleb or cyclo surgeries. So these are the baseline characteristics. So the mean deviation, the mean MD deviation of the visual field was -14, -15. So they're like really damaged. They would fail all our other trials. No? And then the mean IOP at baseline on maximum medical therapy is 23 millimeters. And then most of them have 3 or 4 meds, even those who had failed surgeries. So the top line results are, number one is 76% of the patients achieved at least a 20% reduction in IOP after we put the iStent. And then 93% of them, we were able to reduce the medicine by at least one medication. And then 53% of them had at least 30% reduction in IOP. So we were quite happy with these top-line results. And specifically, so first, 90% in the maximum medical therapy had this greater than 20% decrease, 73% in the failed surgery group, and these are the subtotals and the graphs. So 53% achieved greater than 30%, and 21% achieved greater than 40% drop in IOP. So a big dramatic benefit to the patients. So responder analysis again, 53% greater than 30, and 74% of them had IOPs of lower than 18. So imagine that we could lower them to less than 18. So IOP medications over time. So we had a drop of a mean of 5.9 millimeters, so 6 millimeter mercury in the cohort at 12 months. So actually, the maximally medicated treatment group had the biggest response. So 35% IOP lowering, more than the failed trap, because these are virgin eyes. So they benefited more from the treatment. So in terms of medication reduction, so 93% had at least one medication lessened in most of the patients. So decreased medications from 3.1 to 2.7 medications. So the good news is we did not have any adverse events in any of the studies. As you know, the iStents, even if we put 3, will never get you to the hypotony situation. And second is we don't want any endothelial cell loss kind of situation. Most of the patients are quiet eyes, so we don't want any iritis or any other loss of BCVA, any inflammation, and visual field loss in the patients. So secondary surgeries, of course, not everybody in any trial, it's not 100%. So 3 eyes still underwent another surgery, and all in the failed surgery group. So those that had needed more surgery intervention are those who had failed glaucoma surgeries before. None of the maximally medicated patients needed an additional surgery after 12 months. So this is a photo of the 3 injects. So I usually implant the the nasal one first. Then I would move 1 to 1.5 clock hours. So, and then 1.5 clock hours to the other direction. So you want to put them as neatly as possible in the trabecular meshwork. So this study was published, this pivotal trial, and I think it was approved already by the US FDA as a standalone procedure. So the summary of the study is it's the first of its kind multi-center trial on these difficult to treat patients, and now we have a standalone MIGS for everybody to use. So before it's always in conjunction with cataract surgery, now you have a standalone MIGS. 76% of the patients had a meaningful reduction in IOP of at least 20%. It's a highly favorable safety profile. So the question now is, have we reached a tipping point where there's an opportunity to change the way we do with the iStent Infinite? Thank you very much.
Good evening and welcome. I've been asked to talk to you about my experience with 3 iStent inject in combination with cataract surgery. I'd like to thank Glaukos for bringing us all together here tonight to talk about iStent Infinite and early intervention in glaucoma. So the iStent inject is a transtrabecular device to lower intraocular pressure by increasing aqueous outflow via traditional pathways It's got a rivet design made out of a heparin-coated titanium, measures 0.36 of a millimetre, both in height and diameter. It comes on a preloaded injector. All right. The standard of care has been to use 2 stents, but with iStent Infinite we now have the option of inserting 3. I've just got a little video here showing the use of 3 stents. So I use a 2+1 technique, which sounds like very much the same as what Bobby does, where you go straight ahead across the angle for your first injection. So you can see here the angle's wide open, and we have some nice pigmentation there, which tells us exactly where the stent should be placed. And then move to the left, trying to get as close to 2 clock hours away as possible. And because we don't have iStent Infinite in Australia yet, we're using 2 of the iStent Inject W. So just getting a second injector now and repositioning to bring the inferior angle into view. That stent's sitting a little proud, so just give it a nudge to push it in. And then, so it's only taken a couple of minutes. And usually at the end of the case, I aspirate the viscoelastic out of the angle to examine for reflux, just as confirmation that your stents are in place. Another thing you can do is inject some vision blue to watch the outflow. You can see the blood coming through the stent inferiorly on the right there. All right, we'll move on. So why 3 stents? Well, it really dates back to this publication by Bellevue et al. In 2012, where they compared 2 iStents to 3 iStents in a small number of patients, 28 for the 2 stent group and 25 for the 3 stent group, and they followed them up for 1 year. And what they found is that the 2 groups had statistically significant reductions in pressure which were similar to one another, but the medication reduction was much greater in the 3 stent group compared to the 2 stent group, so 2.7 versus 0.7. So this raised the possibility that putting 3 stents in was more efficacious than 2. And then some years back, Glaukos started telling us that the iStent Infinite was in the pipeline. There were a number of significant advantages to it. One is that it will come preloaded with 3 stents instead of 2. Another aspect of it is the injector design, which gives you unlimited shots versus the 4 maximum shots which you get with the current injector. So knowing that this was coming along, we thought we should do a study looking at how 3 stents performed, so that by the time that it becomes available, we've got a bit of an idea on how it compares to what we're doing. So we started this prospective multi-centre trial in Australia, looking at the use of 3 stents. We did it in combination with cataract surgery, and we've also done it as a standalone treatment, and I'm going to present you the cataract surgery data tonight. So we've got recruitment centres across Queensland, New South Wales, Victoria and Western Australia, and these are my 10 collaborators. All right. In the iStent combined with cataract group, we've recruited 104 eyes with a mean age of 74 years. The main diagnosis is primary open-angle glaucoma, accounting for 69%. You can see from the visual field indices that on average the glaucoma is fairly mild, with a baseline intraocular pressure of 16.1 millimetres of mercury and on 1.86 medications. We surveyed the surgeons to indicate the reason for offering surgery, and in 49% of cases the indication was to reduce pressure. In 36% of cases it was to reduce medication burden. In 15% it was to achieve both of those things, and in 1% it was to avoid filtration surgery. These are the intraocular pressure data. So from a baseline of 16.1 out to 18 months, there's been a 3.36 millimetre of mercury reduction, which equates to 20.8% reduction. Medications have reduced from 1.96 at baseline to 0.67 at 18 months, representing a 65.8% reduction from baseline. And if we compare the medication use at baseline in 18 months, you can see that only 19% of eyes were on no medication at the time of treatment, and this has increased to 61%. And the number of eyes taking one or more medication has gone down from 81% to 39%. Looking at crude markers of glaucoma progression, Humphrey visual field mean deviation has decreased, which is not surprising given that they've had concurrent cataract surgery. The pattern standard deviation has reduced from 502 to 331 decibels, and the mean retinal nerve fibre layer measurement on OCT is approximately the same across that 18-month follow-up. The main reported complication is peripheral anterior synechiae to the stent, and at 6 months this was seen in 6% of eyes. And we've only had one eye so far that's gone on to have a subsequent IOP lowering procedure. That eye required a deep sclerectomy. So just to summarise our experience with using 3 iStent inject in combination with cataract surgery, there's been out to 18 months, there's been a mean IOP reduction of 20%, along with a mean medication reduction of 65.8%. And overall, so far the safety profile's been very good. Thank you.
Good afternoon, everybody. Good evening. Thank you all so much for being here. Thanks to Glaukos for the opportunity. I'm going to talk a little bit about some pearls with the implantation of the iStent Infinite, but I'll get my slides up and then we'll start. I have a little intro video. I have way too much time in my hands when I'm flying across the world, so I like to work on some fun videos. I'm also a musician. I have in a band called Funkadesi, mixes Indian funk and reggae, so I try to incorporate music as well. So let's see if we can play there. Here we go. Yeah, that's what you do a 15-hour flight from Chicago to Taipei. Anyway, well, thank you so much again. Excited to be here to talk to you about my experiences and some pearls. Which way do we go? So, Tina mentioned to you what is this idea of interventional glaucoma or earlier intervention in glaucoma? Thank you for that. For me, real quick, I think for me it's more about not surgery, not rushing to surgery, but more about not having to choose anymore. For many years when I came out of fellowship, it was if I want to have good quality of life, well, I really couldn't control pressures very well because we know what happens with topical drops. Other way to look at it was not having to choose anymore between knowing that compliance is an issue, addressing it early enough, but also maintaining high safety while we are addressing compliance. It was one or the other. And I think now with all the tools that we have, whether it's laser, drug delivery, as well, of course, as the iStent, other MIGs, we have opportunities now to intervene earlier and really not have to choose any more between one or the other as well. Because truly, poor compliance is probably the biggest barrier that I face in medical management of glaucoma. We all understand how tough it is for our patients to have to take these medications as well. And ocular surface disease, we all know the more bottles you add, the more risk of ocular surface disease. And we did a study, the phase 3 trials of the iStent inject, showing us in the orange, cataract with the iStent inject. Gray is cataract surgery alone. And we found that patients who had the cataract with the stent had improvements, more improvement in their quality of life scores, what we call the VFQ 25, as well as the OSDI, dry eye scales, improvements more than cataract surgery alone. On the right, in the orange, those people who are off medications had a greater improvement in their patient-reported outcomes, meaning better improvement in their quality of life than those who were on medication. So part of the definition, as Colin mentioned, is not just, or part of the goals, rather, of interventional glaucoma is not just bring the pressure down sometimes, it's maybe just get them off the medications, even if the pressures are doing okay. And that's why the definition of success can be different for every patient, depending on what you're trying to achieve. So when I look at my first pearl today, it's really getting a good view. That is the key. Imagine you're inside the eye, this little guy inside the eye, and you're roaming around, and you're looking almost like you're looking at a nice, beautiful piece of artwork in front of you. That's how you want to see the angle. That's more important than anything else, because the more perpendicular, the more en face that trabecular meshwork is, the easier it is for those stents to sit in the canal the way you want them to as well. So that's kind of the idea, imagining this little guy in the eye looking at, and not really want to hurt him there. So let me ask you, my panel, does that look like a good en face view? What do you think, Bobby? I want to call on you. Little fuzzy. Little fuzzy. You can see the trabecular meshwork. You probably could get away with this. No problem at all. But look what happens. The subtle changes that we can do with our gonio prism, with the eye turning, or the scope can make a significant difference. Now watch what happens to that view. So it looks not bad, but watch there. See it there? It's a little turn. One more time there. So there you go. I see the trabecular meshwork. If I turn a little bit more, turn nasally, look at that. Do you see that en face view there? So that subtle change can make a big difference between how effective, how efficient, and how predictable and how precise you are with getting that stent in the canal as well. Other thing you want to watch for is how we push on the eye. When you are starting out with MIGs in general, whether it's the iStent or any MIGs, one of the most common, I think, learning curves is how to use that non-dominant hand and put that gonio prism on the cornea without pushing too much on that wound or on the eye in general, and having the egress of viscoelastic out of the eye. And so I'll talk about the Infinite, which is a nice benefit, but here's just with an older version of the iStent many years ago. But I'll show you one of my first cases I ever did. This is back in 2012, I think. And it was just, you can see I'm pushing on the eye and I'm pushing on the wound, and really I'm getting a lot of stria of the cornea. So that's why it's important to just kind of relax and get comfortable with gonioscopic view, making sure you're not pushing too hard, putting enough viscoelastic in the eye. So these are all the learning curves that are important, so that maintaining that good view, otherwise you can't see what you're doing no matter how smart and how good you are as a surgeon. We want to always maintain a good view so we know the anatomical landmarks as well. Number two, what's another pearl? It's important with the iStent inject to also be perpendicular to the trabecular meshwork. There's a trocar on the Infinite and even the inject that allows you to know exactly where you are. Well, if the trocar is not perfectly perpendicular, if it's bent, then it's going to be hard for that stent to travel through that trocar into the canal. It may be under-implanted, or sometimes it may pop back into the anterior chamber. And so here's an example, and this is the inject, not the Infinite. I'll show you a slide in a second of the Infinite, but I want to show you, look at that trocar in close up, and I'll actually press play here, and I'll do even a higher mag to show you what I just did. So it was hard to see, but I had to adjust there. I'm going to go a higher mag. Now look at that trocar. See, it's bent to the left, so I had to straighten out. And there we go. Now I straightened out. Now I am more perpendicular. I can press that button to place that stent in the canal. It sounds simple, but that little adjustment to keep it more perpendicular can help ensure that that stent stays in the canal as well. So again, simple things like that as Bobby mentioned, very hard for bad things to happen with the iStent inject or the Infinite, but those are the small things that you want to make sure that you pay attention to as well. The other thing is use that wound as a fulcrum. Colin did a good job of showing you those 3 stents, the beautiful view that he had. And I think it's important to utilize the fulcrum. This is again with the inject slide, but bottom line is that wound on the bottom there. That wound can help you stabilize the trocar or the loader. And to get to that left stent and the right stent, if I want to go to the left, I use the right side of the wound, and then I can turn to the left and stabilize my hand. If I want to do the right stent all the way to the right, I just go ahead and go to the left side of the wound and go ahead and use that to stabilize my hand for the right side. Sounds simple again, but that wound can, again, you don't want to push down on the wound, but just using it side to side to stabilize your hand can really help get that 2 clock hours apart. Now, don't worry. If you cannot get 2 clock hours, as Bobby mentioned, if you're about a clock hour and a half, that's okay. It's not the end of the world. We try to get as wide as we can just to get more access to the collector system as well. So let me show you a video. This is the trocar. What's really unique about the iStent Infinite is it has this auto-retracting sleeve. So with the inject, we have to pull it back manually with our finger to expose the trocar. Well, here we have this retractable, malleable sleeve here. And what's nice about that is when it goes through the corneal wound, it also not only retracts, but it blocks the egress of viscoelastic out of the anterior chamber. Now that black button is what you press to release the stent into the canal. That purple button is called the actuator button, and that's what you press to deliver the next stent or get the next stent ready to go. So you press the black button, release the stent, press the purple one to activate the next stent in ready position. So I just want to show you what it looks like in real time there as well. And that's a trocar. Now the trocar is shorter than the iStent inject. Sometimes it's harder to see, but it's more stable. So it doesn't bend quite as much as we do see sometimes with the inject. So as these guys showed you great videos already, go straight across, come back out. Slight dimpling is all you need. You don't have to push too hard. I'm going to use the right side of my wound there. I'm going to go a little bit more to my left. That's not quite 2 clock hours. This is one of my first cases there. So I'm only about a clock hour and a half, as I was mentioning earlier. But that's okay. And then we go to the right here. And sometimes if I can't get a good view, what I'll do is I'll just move my hand position. I'll move my chair a little bit there to get a better view into that one on the right side there. Just go ahead, slight dimpling. Press the button. Gently come back. Don't rush too far. To wait for half a second to make sure it's in place. And go ahead. And you see that reflux of heme? I actually like seeing that. Small amount of heme reflux means you have a good patent canal. Watch the blanching nasally. Ready? Watch the nasal vessels. My favorite part. Ready? Oh, look at that, everybody. You see that? All those blood vessels nasally turn white. That's the fluid wave. You don't always have to see that, but when you see that, it's nice to see that the real time as well. Here's a case too. I'm going straight across. Again, one more time. Now, what's nice about the the Infinite compared to the inject, the reason why some of you whoever used it feel like the inject or the Infinite is a little more stable when you press that button, part of that reason is because with the inject, what's happening, there's actually more of a hitting spring type of mechanism where the loader will push it, will actually hit it into the canal. What the Infinite does is it pushes it and then releases. So instead of hitting it like a hammer, it's going to push it and then come back out. What that does is it prevents that sudden reflux of the stent into the anterior chamber, and it feels more solid in your hand as well. So for me, that's why when I press the Infinite, I just feel more comfortable. It feels more solid when it's delivered into the canal as well, and less chance of the stent coming back into the anterior chamber as well. So just showing you these 3 stents. I'll do one more video here real quick. Now, if you have a good view, you don't have to come out for that 3rd stent. So this is showing you here again. Do the first stent across like these guys showed you already. I'm going to go to the left now. Try to go, there we go. This is more like 2 clock hours there. I'm getting more close there. And then if I have a good view on the right, I won't come out. I'll just kind of use the left side of the wound there to get that nice fulcrum and then stabilize my hand and go to the right side there. The slight dimpling, a little bit of some stria in the cornea. And then the stent is all complete. And there you go. So again, stability and good view and en face view is really the key to success of the iStent inject or the Infinite as well. That 3rd stent to get into the right is important to use that wound as their fulcrum. See how nicely placed they are as well. So I just want to show you a case here, and then just going to talk about a few comments in general. This is an example. I've done a lot more standalone recently. So I showed you one of those videos. Most of those were cataract combos. But what I'm doing a lot more now is the standalone type of patient, as Colin mentioned. Those patients, let's say, are on 2 or 3 medications. Let's say they've had an SLT, already had cataract surgery before. That's the kind of patient, even if their pressures are quote-unquote controlled at target, the question that I've been asking myself, and I'd love to hear the panel, is what is your definition of controlled glaucoma anymore? Is controlled glaucoma only field loss stability, nerve stability? Of course, the most important. Pressures are at target. But if the patient has a difficulty with staying on medications, hyperemia, cost, side effects, physical attributes, forgetfulness, whatever that barrier to compliance is, in my opinion, in my hands, and with the data we have already published now, that patient has a poor likelihood of staying on that medication burden long term. I will put in my chart uncontrolled glaucoma based upon compliance-related issues. Then that justifies the reason why I'm going to go in there. It may not be to reduce the pressure, may just be to reduce the drop burden for those patients. That's been happening a lot more in my practice, and we're seeing the benefits from an efficiency and flow perspective in the office, as well as from the patient perspective. So here's an example of a Hispanic female diagnosed with glaucoma. Bottom line, had cataract surgery before, had SLT a couple times, more of the right and left eye was getting worse, on 3 topical medications. T-max was in the upper 20s. Now pressures are basically in the upper teens with some fluctuation, 3 to 4 or 5 millimeters of fluctuation. But you see that dry eye in the right there. You see some significant SPK. Patient really having a hard time taking this drop in the right eye. And so for this patient, even though the the fields may have been stable in patients like this, if I see that kind of a cornea, that's a patient who's not happy, and they're going to complain and really have a difficult time with daily functionality. Low hysteresis, I do a lot of hysteresis, means low shock absorbing ability of the eye, risk factor for glaucoma progression in some studies as well. So this is a patient, no doubt, that is not happy with drops. And you can see on the right there, the OCT, that was a baseline OCT. Baseline RNFL had some suspicion right to more on the left, but on the right, you see a few years later, significant thinning and progression in the eye, in the RNFL in both eyes. So patients definitely getting worse. You see progression on the RNFL on OCT over time. There's the optic nerves. And so this is a patient who has significant damage, moderate glaucoma right eye, getting close to fixation right eye. So this is a patient we don't want to wait on. And I didn't show you the baseline, but the baseline visual field in the right eye showed a small nasal step. Now we have paracentral changes. And so this is the kind of patient we can't wait. And a real quick story I'll tell you. I know we're probably running close on time, but real quick story. My dad was an ophthalmologist, and I remember I came out of fellowship at Duke, and I came my first year. My dad sat down, and we love our chai, Indian chai. He goes, "Son, sit down. Tell me how is glaucoma doing?" I said, "Dad, glaucoma is so easy. I don't know why I did a fellowship." And then 5 years goes by. My dad, "Son, sit down. How is glaucoma doing?" I said, "Sucks. I hate it," because everybody was getting worse. It just takes time. Progressive disease, and just the longer we wait, the more difficult it is. So I'll leave you with this last slide here. I just think the earlier we intervene, the better chance we have of obtaining that target pressure, right? It's a conundrum. The more we wait, I always tell my patients, the glaucoma is like a big ball, a big stone on the top of a hill. We can hold that stone when it's right there, but as it starts to roll and gets faster and faster, harder to stop. Let's stop it up here. Target pressures are higher. These conventional MIGS procedures like the iStent Infinite will get us there more likely with higher target pressures. There is a significant benefit to reducing the drop burden even for one topical PGA. We minimize the impact on quality of life, but BAK, benzalkonium chloride, the PGAs and the meibomian gland dysfunction, trabeculitis, we have data now showing us that trabecular meshwork fibrosis occurs with chronic use of topical medications. The outflow system can be scarred. Goblet cells, if we do a trabeculectomy, can be affected as well. And the MIGS is great to co-manage with your colleagues, depending on where you are in the world. And I do think it doesn't always completely prevent traditional glaucoma surgery. We still need our trabs and our tubes. But if we can delay it a few more years, still a significant benefit for the quality of life of that patient as well. And I think it's important to not minimize anymore because of the data we have with the LIGHT trial and other trials out there showing us, despite the same average reduction of IOP, reducing the drop burden can be a significant benefit from progression as well. And listen to our patients. They were telling us without telling us, they will tell you that they're not compliant. My vision comes and goes. I have to blink to clear up my vision, dry eye. If you ask them, what's the name of your medication? I have no idea. What's the color of the top? I have no idea. You can't read the label because the label's all washed away. It's been taking that same bottle for a year. They're not compliant. So pay attention to compliance. These patients are there as well. So last slide here. For me now, my tradition now is beam of light first, SLT. Then I do drug delivery in the United States a lot, as well as MIGS. And I'll do more MIGS, more SLT, do some MIBS, some bleb surgery if I need to. But drops are always there for us, but as a bridge if we need to as well. So thank you. I'll try to stay on time there. But thank you for the opportunity, and love to have a discussion and go from there. Thank you.
Thanks very much. I like your disco ball at the end. Is this like the start of the evening now? Okay, so I think, thanks to all the three speakers, I feel that it's been really good explanation of everything about the iStent Infinite, and hopefully all of you will be able to have an experience. But I'd like to just ask each and every one of you here, you mentioned about, all the tips and tricks, and, certain individuals that you would offer iStents to. I mean, how do you open the conversation? For example, people that may not have had the opportunity to broach the subject. So should we start with Paul? If there's a person that you feel would benefit, but they're clinging on to their eye drops, how would you broach the subject?
I think the idea is that not trying to convince them or sell something. I think it's trying to address their problem. I think of it as we are the solution to their problem. Meaning, the key is to identify a barrier to compliance. Every single one of the patients I do surgery on, there's usually a reason why they don't like to take drops. And identifying that, it could be a cost issue for some people. In the United States, drops are very expensive. Or it could be that they physically can't put the drop in the eye. So that if you can identify that patient, you say, Mrs. Smith, you're telling me that you're having a hard time taking those medications, or you're telling me your vision's coming and going, your eyes are very dry. That drop can cause irritation to the glands that produce oils. That's why the surface of the eye is not smooth. That's why your vision comes and goes, like a dirty car windshield. So I have an idea. Let's go ahead and try to remove that topical glaucoma drop, remove some of the chemicals of the eye that might help that surface of the eye. If it doesn't, we have other things we can do for that dry eye. So it's identifying a compliance issue and then saying, I have a solution for you, versus saying, I want to do surgery for you as well. That's kind of what's helped us.
Thanks.
With us, cost is an issue here in Asia, because we ask our patients to pay for the stent and to pay for any additional surgery. So the opportunity to present an intervention or early intervention comes when there's a change in the condition. For example, if you are shifting from 1 med to 2 med or 2 med to 3 med, that's an opportunity to tell the patient medications may not be working for you. Second is, as Paul said, symptoms. If they are having side effects to the drops, there is an opportunity to present an alternative to eye drops. And the third is, as Colin presented, is when they have cataract surgery. So all the patients who are on meds in my practice who want or need cataract surgery, I bring up the opportunity to put a mixed device in their eye at the same time, because they will feel that, I need the surgery for vision, and this is like a useful add-on for their glaucoma too. So an opportunity to change something, or there's a need to change something in their condition or their therapy, that's when I inject an intervention because of the added cost to it.
I think when it comes to the discussion around using iStent with cataract surgery, that's an easy discussion to have, because it's about being opportunistic. You're subjecting the patient to an operation anyway, and you're using that opportunity to do something positive for their glaucoma. As Paul mentioned, even getting them off one drop will have a significant benefit in terms of their quality of vision, quality of life, the cost of their treatment going forward. And the worst thing that can happen is that they're not going to get the IOP reduction that they're expecting. They still get the benefit from the cataract surgery. So there's a lot to be gained and not a lot to lose. I think the discussion around standalone is a little bit more difficult, because, from our data, probably around 10 to 15% of eyes do not respond. So you're subjecting the patient to an operation with that 10 to 15% chance of getting no benefit from it. And because you're not taking the cataract out, there's no visual improvement that goes with that. So that's a little bit more of a difficult discussion to have, but you can frame it in terms of the potential gains that can be made by getting them off their medication or reducing their medication, or even avoiding the need for more invasive procedures which carry even more risk.
Okay, right. So what I'm hearing really is to turn it around to psychologically convince the patient that, you've got a solution to something that is causing them a daily problem. Also have an opportunity to introduce a new intervention, if you are considering to increase or scale up the medications, that's a good time to offer them options. I think, even in our department in Singapore, if a patient has got cataracts and they're on one drop, the thing is that we have to say that this is an option. Doesn't mean that they're going to take it, but you have to tell them that they have an option because it's now available. So I think as doctors, we have a duty to inform them, but they may want to think about it. That's fine. You can plant the seed and then they come back, they thought about it and they'll say, you know what, I'd like to do that now, doc. So, the other thing is that if you give them an idea, that you don't scare them away and just say, okay, go home and stew on it, and I'll see you in 3 months. Take these these bottles, I'll prescribe you some more Alpha-Gan or something, and come back and then think about the iStent again. And then, they come back and they say, you know what, actually, I think I'm going to go for the iStent instead. But, it's a psychological thing. So, don't bully the patients, but also to sort of let them come round to the idea. Because at the end of the day, we just don't want them to be suffering. So one of the things I want to also ask the panelists is that, we're talking about the use of the iStent for early, intervention, like, early glaucoma. But what have you had to consider using it for patients that have had tubes or failed trabs?
Yeah, it's a great point. So I was lucky enough to be involved in the trial for the iStent Infinite in the States. And when Glaukos first came to me and said, hey, you want to be part of this study in patients who had minus decibels of minus 15, history of trabeculectomy and tubes and ECP. And I said, are you kidding me? I thought we can't reopen the conventional pathway once we divert fluid away. That was the conventional thinking. I said, are you sure you guys want to do this? And they said, yes, we want to do this. I said, okay. Well, I was surprised. There were patients who actually were able to get reduction in IOP. The goal was not necessarily to reduce the drop burden in those patient populations. So I have done it in tubes and history of trab patients where the cons was not very healthy. The angles still look pretty good. I said, let me go ahead back in there and try to reopen it. And what you tend to find is that you're not going to get to 10, 12 lane. You'll get in the middle teens a lot of times or lower. But you're going to still need to be in drops for a lot of those patients. But again, the goal sometimes is not to get it down to 10, maybe just to minimize fluctuation, get them down enough so that we can hold off on a trab or another tube for at least many, many years if possible as well. So I would say it's not 100% guarantee, but it does work in some patients. And it's worth a try. To Colin's point real quick, yes, some of these patients may not have the effectiveness, especially in a standalone indication. And that's a fear for all of us. We don't want to go into surgery and not perform and not deliver on our promise to our patients. But I do think it's important to tell them there's no one procedure for any patient that's going to be 100%. We have multiple tools and that we're on a journey together. I'll try this first. If this doesn't work, we have other options that we can still do. And I think setting that stage early on so they expect and know that there's other options if this doesn't work puts a little less pressure on us.
Well, this is something we can offer to patients who have no other recourse except a tube. So I find it easy to offer this to the post-trab who still need 2 or 3 meds. Again, the patient may not want another surgery, but then again, what's the alternative, right? Now, if they need, usually after trab, we would offer a tube, right? And I don't like tubes. So I would rather do this first, but let them keep in mind that the tube is there later on. Or this can be after the tube if that still doesn't work. So you have an additional device or a fallback procedure. The tricky part is, as everybody said, is we have to prime the patient that sometimes even with 3, it's still not low enough or not enough to address their problem, and we need to face it that we need another procedure. So it's like premium IOLs, right? Premium IOLs tell us that we tell them the benefits, but we may not get them to the satisfaction level or the spectacle independence. But we still push on because we know that it benefits them. And in majority of patients, they do benefit. In majority. Not all, but majority.
I definitely think there is a role for iStent in advanced and complex cases. And, it's evidence-based. So we've got the FDA trial. that shows that it works in those patients. We've got registry data that's coming out now across a spectrum of disease severities and complexities, which shows that it works. And I think there's different reasons why you might want to consider it. There may be patient factors. So, for example, they've been burnt by their previous failed surgery, and offering something similar to that moving forward, they'd be very reluctant to go ahead with. So to be able to give them something that's completely different with a significantly better safety profile is something that they may be willing to accept, so it's wonderful to have that in your toolkit. The other aspect of it is that from the surgeon's point of view, you may be in a situation where you're considering, a revision trabeculectomy or a tube or something like that, not because you want to, but because that's all you've got available, right? And with something like an iStent inject, it's an intermediate step that allows you to treat your patient more safely, and you may get a great result from that. And examples like a 90-year-old monocular patient with 10 degrees of field, you don't need to keep their vision going for 20 years, but you may need to keep it going for 5 years. And, if you do a trab on them, you might blind them. But putting in a couple of stents may be the solution that they need.
Great, thank you. Thanks very much. So I know that we are between you and dinner, but I think I'd like to just really thank the speakers today. I always learn from these three experts. But I think at the end of the day, today I think the summary is really that we have options. When we have real options to give to our patients, to offer our patients, and it doesn't have to be the conventional way of doing things. Okay, remember early intervention in glaucoma, not interventional glaucoma, because we want to intervene at an earlier stage with the right personalized treatment. It doesn't have to be eye drops, but it's the conversation that you need to have to the patient to offer the right treatment that is suitable for that individual. So I hope that you've learned something from this evening's discussions, and I hope you enjoy the meal and the rest of the evening and the rest of the Congress. Thank you very much, and thank you to Glaukos. I think the concept of interventional glaucoma is describing an idea that with the advances in surgery and different devices that are now available to treat glaucoma means that we have larger options to offer our patients at a much early stage in their disease. And that equates to probably better control in the longer term and also a much better quality of life for our patients.
So for patients who have glaucoma, we generally do the regular iStent inject for the mild to moderate glaucoma. But for those who have severe glaucoma, we know that the usual MIGS device of 2 iStents is not enough. So the iStent Infinite definitely expands to the severe range. So now we have one kind of device, the iStent Infinite, which can address mild, moderate, and severe glaucoma, one device for all types of glaucoma.
I think for me in general, what I still love about minimally invasive glaucoma surgery is the maintenance of high safety, but also with efficacy. And I think with the iStent Infinite, we do still maintain high safety with minimal trauma to the target tissues. I think an efficient ergonomic system to help reduce IOP and improve outflow.
Well, the advantage of iStent Infinite is ease of use and speed of recovery. So surgeons who are familiar with the anterior segment and who are familiar with performing intraoperative gonioscopy will be able to use it well with a very short learning curve. And the benefit to the patient is the speed of recovery. So there's little to no impact on them in the early post-operative period because the risks and side effects on the treatment are few.
So I think iStents fit into the whole spectrum of the tools that we have
to treat patients surgically or even with laser. It is complementary to the other existing techniques and technologies that we have. So it fits in very nicely in terms of offering patients, even if it's quite advanced disease, they may well still benefit from an iStent. And you can go all the way to early stage disease and they will also benefit. And so iStent can then be able to be slotted in according to the patient's needs.